Doc, I let people know that you have a one-time conflict and you'll be leaving soon. And Amy, I believe, emailed all of us that she'll be joining late. So I wanted to just go ahead and jump right in and thank you all for being here again. I thought it might be useful to talk about the format of the meetings this week, how I'm planning, how I'll be trying to structure meetings in the future. So I thought each time it would be helpful to start off with some notes from the chair to follow up on things that may have happened in the previous meeting or questions that are out there. So just as a quick recap, the first meeting the purpose of that was to get introduced to our work through the charge and overview document and get grounding in what the city departments that touch this area do and what they don't do in the district. So that was the purpose of having the city planning department, the building division, and the historic preservation planner in. Because what I've found in, even trying to address something simple in the neighborhood, sometimes the various players refer to another player because it's either in their jurisdiction or there is the perception that it's in their jurisdiction. So that's why I thought it would be useful to get that kind of grounding. As for follow-up, I referred your recommendation to the mayor that 2 new appointees be added to the task force. One with lived experience, though they might not have a formal housing situation on the block, and someone that does have a formal housing situation on the block. I have heard from and followed up with some people who are interested in at least one of those roles and reached out to some others. I've updated the mayor, but we're not ready. He's not ready and doesn't have enough information at this time to make any appointments. So I'll be continuing to reach out, and I continue to invite you, should you have ideas for me of people I should talk to, whether or not it's a person who you think would want to be on the task force, but maybe somebody who could recommend somebody else or would just be useful to, to make connection with. I'd be happy to do that. So hopefully by the next meeting, we will have those appointees. That's my hope. And what is beneficial about recording is that people can get up to speed if they need to. There was an unanswered question. This is the other point of doing these notes at the beginning. There's an unanswered question from the group, which came through the post meeting survey, which was somebody brought up a very good point that it was a little unclear how we're going to handle voting in this forum. So what I would propose, and we can see how it goes today by there's something that we can vote on, not a major item, but how to vote is the action item. So what I would pose to the group is sort of what my understanding of what the person who wrote in suggested, which I think it's about putting that whatever the action item is out there. So in this case, how the group will vote. Spend some time in discussion of it and then go around individually so people can voice yes or no. We could also handle it an alternative way that feels more like the Roberts Rules method, which is to define the action item in the same way, then ask for a motion and a second and then do the vote. There's usually discussion in between there too. The reason I'm proposing that we keep it a little more simple and define it, discuss it, then go individually to a vote is that I feel that if more community members join the task force, it's just a clearer way. Sometimes Robert's rules can get a little wonky, but we can certainly discuss that and change it. So we may want to hold this vote at the end of the meeting, since I know that Michelle has prepared a presentation for us that I'm sure everybody will want to get to, but I'm just going to throw that out there now so you can be thinking of what you would like to see. Yes, John, please.
Sure, and obviously staff would not have 2 votes.
That's correct. 1 vote.
I think you and I think had some discussion about that at one point, but obviously there's two people from the organization involved here, and we don't want to take up more than our fair share of whatever sort of space is being carved out. So.
Absolutely. So yeah, if you and Michelle need to confer, you can do that. Okay, so I've covered the update about the new appointees. So also in the format, going on with the format of the meetings, each meeting I'm going to attempt to have, at least in the beginning, subject matter experts come in and present on various topics. The grand vision is to have the topics kind of grouped together by theme. As it turns out, that might not always be possible, depending on people's availability and so on. I am finding, and you all might be finding in your work, that numerous reach outs are necessary these days. I'm not sure if it's just the pandemic and everybody's inboxes were already overflowing, and now this is the main way that we communicate, or what have you. But that has been a little bit of an issue, so I'll be ramping up and getting with contacting people way in advance. So again, if you have any thoughts on who you'd like to see invited in, please send me those at your earliest convenience. We'll have time at the end of this meeting. What I would like to do is spend a little time with each of you getting input on what kinds of categories we're seeing. What are the categories that we definitely want to make recommendations in, at least with the knowledge that we have of the situation at this moment. So we'll discuss that later. So with each subject matter expert, there'll be time for a Q&A, and then we can have a larger discussion, time permitting, that's not just questions and answers. I will be providing a summary document, such as the one that you received before this meeting. The summary document is not meant to be exhaustive minutes. What I hope that the summary document does is to lift up whatever the key points were and just simply provide a record of who was here, who the subject matter experts were, what some of their main points were, what some of the main questions that came up were, and those answers. And then give everybody a chance to review them the next weeks and make any corrections that you would like to see in those. That's sort of like minutes, and then be able to have these on file. My thought is that these can help guide us when we get to the work of designing recommendations, to be able to look back and understand what the main points of those meetings were. They can also help us understand where we want to know more information and call those people back. So those are the main points that I wanted to discuss today. I do also want to say that just in reflection of our last meeting, one of the things that I was really left with after reviewing the recording again was Kathy's point that things may look different today, but the issues that we're grappling with have existed or have continued to exist in very similar forms for a very long time. So Kathy also pointed out that there have been other task forces that reached a point where they couldn't move forward for reasons of lack of clarity, or I'm sure many reasons. That this task force has some funding tied to it. So I'm really hoping that the group that's here and the funding can help us get over that hump. But I mentioned the kind of no new problems under the sun idea, not as a way to be dispiriting, but also to recognize that there are solutions being implemented in the world that we can look to, and that we can also expect that we're going to be able to make some recommendations that will be actionable. That was the other takeaway that I got from our last meeting, that there's a range of things that we can address. It's possible that we won't be able to address them all, but in my view, any incremental change for the better is going to be a benefit. And to the extent that this group can help catalyze that, I'm very excited to be a part of it. So just wanted to mention that. And then if anybody else at this time wants to share any other thoughts or questions that they have before we move on, or reflections that you had after the meeting, I invite you to do that. We'll also have time at the end, but please feel free, especially if you know you won't be able to be here. Okay, so today's action items at the end of the meeting will be to vote on how to vote. And also we are going to, this isn't an action item, but something that we'll be doing is brainstorming categories that we want to make sure to make recommendations in. Okay, so with that, Michelle, I believe that you have screen share capability.
Okay. Let's see. Yes?
Yep, we see it.
Excellent. Okay, so again, I'm Michelle McElroy. The Southern Tier AIDS program also has a DBA, a doing business as designation as Southern Tier Care Coordination. So you also see that listed here on the slide. A lot of the services that we provide that are Medicaid reimbursable services and the medical services that we offer through the Health Hub for people who use drugs are under the Southern Tier Care Coordination name, so as to help protect individuals' confidentiality. So I was asked to do a bit of a harm reduction overview today, talk a little bit about what harm reduction is, what it isn't, give some examples of harm reduction services we offer, give some historical context to harm reduction, and also provide some examples of harm reduction that are not things that we do, but that are other examples of harm reduction in other countries. Okay, so according to the World Health Organization, harm reduction encompasses interventions, programs, and policies that seek to reduce the health, social, and economic harms of drug use to individuals, communities, and societies. And according to the Harm Reduction Coalition, which is a United States-based organization, harm reduction is a set of practical strategies and ideas aimed at reducing the negative consequences associated with drug use and sexual risk behavior. Harm reduction is also a movement for social justice built on a belief in and respect for the rights of people who use drugs. I'm not going to read the rest of the slide to you, but the Harm Reduction Coalition does have an excellent website with some additional resources about that if you're interested. And at the end of this slide deck, which I'll send out with everyone, are some other resources, references, and related readings. So some basic harm reduction principles: recognize that risk exists on a continuum and that people continue to engage in behaviors that inherently have risk. Recognize that those same humans are entitled to accurate information and supplies so as to work to reduce their own personal risk and be empowered to do so in a manner that is effective and also feels accessible to them, and work to reduce the societal harm and stigma that is associated with various risk behaviors. So it's sort of a multi-level approach where you're going to meet an individual where they are, and then also attempt to address on the community and societal levels those negative stigma impacts. So harm reduction philosophy as it sees drug use is along a continuum, with abstinence as one of the many possible goals. Meets people where they are in their process of substance use, treatment, or recovery, maximizes options, and focuses on client-centered care. We prioritize achievable and client-selected goals because we believe that those are the goals that are most likely to be successful, and they're also the goals that are most likely to maintain engagement with clients when we're working on goals that are important to them. Harm reduction is neutral regarding legalization or decriminalization. Also, drug-related harm cannot be assumed or generalized. Not all individuals experience harm from using substances, and drugs can meet important needs, particularly for people who cannot access traditional care systems. We want to avoid exacerbating the harm caused by misuse of substances, again, by providing accurate information, education, and supplies to reduce risk and harm. People who use drugs are more than their drug use, as all people are more than their medical diagnoses. We try to use people first language, just as we try to use people first language when talking about all other diagnoses, disabilities, etc. Treat people who use drugs with dignity as human beings first. And it is, again, also considered to be a larger movement for social justice and policy change in order to reduce the negative impacts of stigma. Several reasons why we use a harm reduction approach: moral or ethical, depending on how you choose to see that. It recognizes the humanity of all people, treats individuals with respect out of concern for their own well-being, but also out of concern for the larger health of our society and communities. It's pragmatic. Harm reduction interventions are evidence-based, demonstrated to work by the CDC, the World Health Organization, many peer-reviewed journal articles, and they're effective. It's also fiscally pragmatic because harm reduction interventions save money. Stigma is the social process which can lead to relations of power and control with stigmatized individuals. It generally leads to status loss and discrimination for the stigmatized. Why does that matter in the context of harm reduction? Because harm reduction accepts that stigma is part of the world, recognizes the intersectionality of stigma and how that is often that someone is stigmatized not just in one arena, but in multiple arenas simultaneously, which creates additional barriers to access. It also acknowledges that when challenging stigma, to meet everyone where they are, all community members, all clients, and that change is really hard. Both personal values and community values change incrementally and not immediately. So while we're doing one-on-one work with individuals, we're also doing work with communities and the society at large to try and decrease stigma and change the way that people believe about people who use drugs. Most healthcare professionals hold negative stereotyped views of people who use drugs. As an entity that was funded by the Department of Health in order to provide specialized services in a health hub for people who use drugs, the reason that that initiative was designed and rolled out by the Department of Health is because people who use drugs are not traditionally well served in medical models. Stigma is a major factor in preventing those individuals from seeking treatment and accessing services. And then the social exclusion created by stigma actually often increases the need for those services. Many of our individuals that we serve feel safer accessing harm reduction services because they are anonymous, not just confidential, anonymous, and they're also low barrier. So you do not have to prove who you are. You do not have to have an ID. You do not have to show your Medicaid card or prove how much money you make. Or prove where you live in order to get these services. This is particularly important for people who use drugs because the reality is that they experience a great deal of associated health risks and increased risks for highly complex infections and other bloodborne pathogen-related chronic infections. And because they have these complex needs, they often end up presenting for care, but the places that they present for care are emergent care centers for the most part, Suboxone clinics, treatment facilities, jails and prison facilities, and syringe exchange programs. They do not generally present at primary care, and they don't actually generally present for specialty medical care either. So I'm going to talk a little bit about early harm reduction, how harm reduction came to be, a little bit about syringe exchange programs, medication-assisted treatment, and then some other harm reduction interventions that we don't use in Ithaca, but that are demonstrated to be effective worldwide. I just want to pause for a second and ask if there are any questions around sort of the basic principles of harm reduction and stigma. Good to go? Okay.
I have an interruption.
Oh, please.
I need to say this. Generally, as a society, there's 4 ways we deal with substance use: law enforcement, treatment, prevention, and harm reduction. Are you coming to that?
If we're going to talk about the 4 pillars, we're not there yet.
Oh, sorry, my bad.
Okay. So historically, harm reduction has really sought to develop strategies that are practical and humane, but also effective for clients and service providers. Things that can be implemented by service providers, received by clients, and that are pragmatic for where clients are presenting. The first application of harm reduction was really during HIV and viral hepatitis outbreaks in Western Europe. This was historically focused on substance use and sexual risk reduction, particularly for people who used drugs and injected drugs. It's also important to recognize that harm reduction understands, as I mentioned earlier, sort of the intersectionality of stigma, and that harm reduction as a philosophy is always trying to address these additional issues of poverty, class, racism, sexism, trauma, isolation that can contribute to increased vulnerabilities within sub-members of our subpopulation. So not only are people who inject drugs at great risk, but women who inject drugs are at even greater risk for some of those most dramatic negative health outcomes and IPV, or intimate partner violence. Syringe exchange programs in the United States began again as a response to HIV in 1992. And those syringe exchange programs were implemented with a very high degree of success in New York State. And one of the things that John and I will talk about, but we probably don't talk about enough, is to say that syringe exchange is the single most effective biomedical intervention ever designed to prevent HIV. Let me say it again. It's the single most effective biomedical intervention ever designed to prevent HIV. There is no more effective strategy for preventing HIV than ensuring that people who use drugs have access to supplies so that they are not reusing or sharing. There are currently 30 programs in New York State. Most of those programs are located downstate, but there are about 10 upstate as well. All of those programs are regulated, waivered, and overseen by the Department of Health AIDS Institute. We have to do daily inventory of all of our supplies. We have to log every single syringe exchange transaction that we do. We have to enroll all those individuals, even though it's anonymous. We have to enroll them all. We have to take their demographics. We have to issue them a unique ID code. So there is actually a fairly heavy regulatory process behind syringe exchange, even though it is an anonymous program. It was designed to be anonymous on purpose, and I'm going to say this as a sidebar, because the reality is that there are many individuals who would not use a syringe exchange if it wasn't anonymous. And the New York State Department of Health knew that. Also true that it helps to provide and afford some protection to syringe exchange providers, because then we cannot be mandated to give information about individuals who may be on probation or parole and turn that information over to probation and parole because we do not know their names. And it was designed again that way by the New York State Department of Health with intent, because many people who need those supplies are on probation or parole, and we still want them to get those supplies. There's a 24-hour on-call phone, which is a mandatory part of this process as well, so that law enforcement can call a syringe exchange staff member at any time to verify enrollment in the program by that person's unique ID code. So whoever staff is carrying the phone will answer, and any law enforcement can call at any time to verify that code is actively enrolled with our syringe exchange. We currently operate 3 fixed sites, one in Ithaca, one in Johnson City, and one in Norwich, a mobile unit, and a peer-delivered syringe exchange program across a 10-county region on less than $750,000 annually. That includes staff fringe, salary, benefits, all the supplies, everything. Again, in the early 90s is when syringe exchange was implemented in New York State. Part of the reason that that was done is because in the early 90s, more than 50% of new infections of HIV were from shared injection equipment, more than 50% of new infections. As of today, that percentage is less than 3% of new infections are from shared injection equipment. Again, syringe exchange in New York State has demonstrated great success in reducing the overall incidence and prevalence of HIV, and particularly among people who inject drugs. Approximately 1/3 of people who inject drugs have chronic hepatitis C, however. And this increases depending on the number of years of use that the person has been injecting. So this is young people, people under 30 already have chronic hepatitis C, approximately 1/3 of them. And as people age and continue to inject, that percentage gets greater. According to the CDC, for a decade now, hepatitis C has killed more people annually than HIV. And that started in the year 2011. The Expanded Syringe Access Program is another program run by the New York State Department of Health to offer sterile supplies in communities, and that's through participating pharmacies where you can purchase syringes 10 at a time. Here's some more data on cost savings. I won't read it all to you, but I'll read you a couple, which says treating one case of hepatitis C is estimated to cost over $75,000. It's important to bear in mind that almost all of those costs are generally borne by the state Medicaid program, which means it's actually coming out of county, state, and federal dollars. Abscesses, cotton fever, sepsis, and endocarditis are also all common injection-related complications that also cost a tremendous amount of money to treat. And someone could have those infections repeatedly over the course of their injection history, particularly if they are not using sterile supplies or they are reusing supplies. I put this slide up because I like to dispel the myth that syringe exchange programs don't send people to treatment. SEP participants are actually 5 times more likely to complete treatment when they enter it, because they have some understanding of what it is that they're going for, what it is that their goal is around that, and how it is that they will be successful once they get there, because they have a relationship with a syringe exchange program that has referred them and prepared them. We send large numbers of individuals to treatment voluntarily. We cannot mandate anyone to go to treatment because that's not our role in the community, but we send vast numbers of voluntary referrals to treatment. In 2020, we served over 2,000 people through our combined syringe exchange and health hub programs. And in 2020 as well, our staff members and trained volunteers personally reversed over 400 overdoses and filled out reports about those overdoses for us to return them to the state. Common criticisms of harm reduction. Anissa asked me to sort of address this, like what is it that people think harm reduction is that it's not? Harm reduction allows risk behaviors by allowing the person to continue to use drugs. We're not allowing people to continue to use drugs as much as we are recognizing that they are continuing to use drugs. And as they are continuing to use drugs, discharging them from our services is not a solution. That will not make them stop using drugs because we have removed their support structure. Harm reduction does not encourage drug use, and harm reduction is neutral about legalization or decriminalization. Harm reduction is concerned about risk management. And so if legalization and decriminalization result in less risk to individuals or communities, harm reduction can support those efforts. And harm reduction does support abstinence. It just sees it as one of the possible options of clients' goals on a continuum. It does not mandate that abstinence is the end goal for all clients. And again, harm reduction is neither for or against drug use. It just seeks to reduce harm to individuals and communities. A quick overview of the 4 pillars of municipal drug policy: treatment, enforcement, which is sometimes referred to as policing or community safety, prevention, and harm reduction. The reason I provide this quick review, which John mentioned, is because this is sort of the framework with which municipals often address drug policy. It's also the framework which resulted in the Ithaca plan, is looking at it from this perspective of the 4 pillars. So just a quick bullet about each of these that's not harm reduction. Law enforcement has a role in every community. However, law enforcement cannot be used to solve the drug problem. I think we all know that. I think law enforcement would be the first to tell us that. Law enforcement is already overtaxed, trying to manage a million other things in our community, and in Ithaca in particular is already short-staffed. But that's true in a lot of other communities across the state, across the country. But you can't arrest your way out of the opiate crisis. You especially can't arrest your way out of the opiate crisis with bail reform in place. So the reality is that law enforcement is pretty tied as to what it is that they can or can't do in these circumstances. It's also true that law enforcement is really expensive as compared to providing community health workers, social workers, mobile crisis intervention, and other community-based resources that address many of the social determinants of health that are the concerns for the humans we're serving and are part of the reason that they continue to be unhoused and actively using substances. As you all know, it has also resulted in mass incarceration and disproportionate impact to people of color. Treatment. Abstinence-based treatment models do not generally demonstrate long-term efficacy, particularly for those with opiate use disorder or polysubstance use history. So There was a time in treatment when many of the individuals coming through treatment were in treatment for alcohol dependency, and treatment was fairly effective, even at long further out benchmarks, 180 days, a year out. But the reality is for people with opiate use disorder and polysubstance use history, that abstinence-based treatment is rarely effective, often not even at the 90-day mark, and certainly not at the 180-day mark. What does make people successful, particularly with opiate use disorder, is using MAT, medication-assisted treatment, in order to do the heavy lifting so that individuals are not triggered to use and that they can have some support while trying to move along a path that is, a challenging path for them to make changes in their life. It's important to note too that the New York State OASIS, Office of Alcoholism and Substance Abuse, or Addiction Services and Supports, did a revision to their formal treatment guidelines and incorporated a harm reduction approach into their own treatment guidelines, so as to reflect that we needed to move away from an abstinence-based treatment model and implement a client-centered care model. That rollout has been difficult for OASIS because that is a very big system and that's a very big change. But if you look around, you will see some of those changes being implemented. You will see that there is now a methadone program in Ithaca that continues to work with people while they continue to struggle. There is another treatment program in Ithaca, REACH, that offers low threshold access to buprenorphine maintenance, right? And does not discharge people if they continue to use or if they have a lapse in their process. It's important to note that those sorts of models that offer treatment, but with some harm reduction, are more successful for individuals, not only at initial engagement, getting them to come, but also in retention and care, keeping them coming back. And then prevention. The reality is for us that by the time that most of our people come to us, prevention hasn't worked. That's the reason that they have landed in the Syringe Exchange, is that the prevention messages they received, if they received them, were not effective, or they did not seem relevant to them. Prevention programs also struggle to receive funding. Even within treatment programs, the prevention arm of treatment programs are generally underfunded. And a lot of the prevention messaging is very black, white, good, bad, which can leave people feeling like, first, if they can't stop everything, that's a failure. But also it can lead to an erroneous belief that all drugs are bad, and so all drugs are the same bad. And we shouldn't be any more concerned about someone using marijuana than we are about someone trying cocaine. Right? So we need to be able to provide people with accurate information about what the risks of those substances really is, because perhaps they are different. Okay, and then some examples of harm reduction that are not operated by staff, but exist in other places. A 24-hour crisis center, a place where you could go to get harm reduction supplies and a Narcan kit, and you could have supervised detox, where you could also get Hep C treatment, be vaccinated, get case management on site. An embedded 24-hour crisis center with embedded services is a harm reduction model that exists in other locations. Housing first models to address homelessness. And I understand that housing first is something that we say a lot about HUD and grants. But when I say this, I really mean housing first, as in we are prioritizing people who are chronically homeless and actively using substances, because we recognize that until we get them housed, they're probably not going to make progress on reducing their substance use. That the first goal is to get them a place to live. And then after that, we will attempt to tackle these other goals, as opposed to expecting them to be able to make those steps first before we reward them with housing. And then other medication-assisted treatment options. We mentioned Suboxone and methadone. In other countries, there is also prescribed heroin. Medical grade, hydromorphone, diacetylmorphine are prescribed for individuals who have long-term injection drug use histories and no success with being maintained on Suboxone or methadone. So the example I provided here is the Crosstown Clinic, and you can go and sort of peek at that if you're interested in it. But it is sort of another harm reduction example that's not something that's currently operated here in the United States, but is effective and is happening in other places. Overdose prevention sites, sometimes also called safe consumption sites, sometimes called safe injection facilities, are currently operated in 39. There are 39 different facilities in Canada the last time I checked. There are 92 facilities in Europe in 61 different countries, 30 cities in the Netherlands, Germany, and Switzerland. Australia also has a facility in Melbourne. And there is an article from 2020 from the New England Journal of Medicine about a supervised consumption site in the United States that has been operating since 2014. And that is a peer-reviewed journal article which catalogs, I think, 5.5 years worth of injections at that site, all of the individuals who have come through there, the number of times that that has been accessed without a single fatal overdose. So again, studies on these types of services generally show that they are effective in reducing emergency calls. They are effective in reducing both unintentional and fatal overdoses. And they also tend to reduce nuisance, public disorder, and petty criminality that come along with substance use disorder. In addition, accessing services, harm reduction services of any kind, is associated with a reduction in the rates of chronic hepatitis C infection because of the access to additional supplies and education and testing services. Okay, and then because you might be a glutton for punishment like me, 2 pages worth of references, resources, and related readings. Some of these are citations for things on the slides. Some of these are just fun articles that you could read for nighttime reading. And then the very last is just my contact information. And if you had additional questions after today, you can certainly reach out to me, and I'd be happy to have an individual conversation about any of these particular elements. I'm going to stop sharing now. And I'll be happy to take any questions if you have any sort of immediately.
Thank you so much, Michelle. I really appreciate that, especially because I feel like I'm a person who knows about harm reduction, but I think it's great to get a refresher, to get more updated information, and to get a broader breadth of information than I've had before. So I'm sure it doesn't surprise anybody here to know that I have some questions. But before I jump in, is there anybody else that wants to ask some questions first? Okay, I'll warm us up. Oh, no, please, who? Go ahead.
I've always, harm reduction strategies are very close to my heart, and it's been effective with a lot of my community members and members of my family and friends. And one of the things that I find the most promising about harm reduction is the capacity to educate the public about being in community with people who use drugs. And so, especially in terms of our project here, having that be a social corridor, and folks I suppose I just sort of, it's more of a comment than a question, but the capacity that we have with harm reduction strategies that have already been implemented in Ithaca to reduce the stigma for members of the public who are interacting with the individuals on a more daily basis, but also when they're going out to dinner or to one of the bars, that kind of thing. Thank you.
Sure, and I agree that one of the hopeful pieces of harm reduction is this ability to affect, as I mentioned, sort of community and society level change around stigma and negative impacts therein. Is that easy? No. Is it fast? No. But do I think that there certainly has been progress in those arenas over the course of the last decade? Yes, I do. Certainly, I've been working at the agency long enough, and John has been working at STAP long enough to tell you that 10 years ago, when we had to go present about syringe exchange in rural communities, the response that we received was pretty different from when we receive calls now asking us to bring the mobile unit, please. Right? Those are very different sort of responses. And there are still a lot of communities that are concerned or resistant about harm reduction services. But there are a lot of communities that are calling and asking for those services because they, like you, Ashley, know that they've had a family member who's been helped by that, or they have themselves read something about medication-assisted treatment and feel like it would be useful, or they themselves have personally benefited. And they're taking that message back, you know, as an individual to their own community.
It's sort of related to Ashley's comment. Actually a question, and it goes back to this concept of stigma. Recently, when I've been speaking to advocates of harm reduction, the stigma portion of it kind of has been more lifted up than what I've recalled in previous conversations I've had other places. So you've kind of shared, Michelle, I think, an example of what reduction of stigma looks like. So that's like a community that once did not want to think about the safety and benefit that could be provided with a needle exchange program, now calling staff for the mobile unit. Am I correct that that's an example of like reduction in stigma, would you say?
Yeah, I think so. I think that is an example.
Okay.
Or it's at least an
that
example of recognition of need.
Okay, because what my question was going to be for you is, what does reduction of stigma look like in practice, and or how to put it into practice? And is the concept of the importance of reducing stigma hard for other community members to embrace or understand?
Ooh. I think whether or not that's difficult to understand or embrace has a lot to do with individuals and their own personal histories. So I'll just say that it's not really so much as a community, it's really about individuals and whether or not they're going to be able to see, embrace, or sort of, you know, feel pushed up against that. I think that it's important to address stigma because what we have seen is that although, yes, there are communities who are more receptive to harm reduction services in recognition of the need, what we don't see is providers who want to serve anyone. So I'm going to say this delicately. Although there has been increased community capacity over the last several years to serve people who use drugs, in general, people who use drugs in Ithaca don't feel particularly welcomed in a lot of care systems, particularly medical care systems. And so the reality is that I think that the stigma piece that we're talking about with providers is very different from general community individuals, because providers have concerns that are not the concerns of individual community members. Providers have concerns about liability. They have concerns about disruption in their waiting room. They have concerns about metrics for retention and care that are dictated by the MCOs and other mechanisms that aren't community individual level concerns, but they are valid concerns for providers. So what we have seen is, although maybe even those individual providers may feel differently, they aren't implementing those changes in their practices, which means that there's still no one available to serve people. Does that make sense? Like the way that we would better serve to reduce stigma, not that we shouldn't do it on a one-on-one individual level, but that also, if we intend to be able to better serve people, we have to do more stigma reduction with general providers, rather than saying, okay, everyone who uses drugs has to go to REACH. Because that's kind of more how people feel, like, oh, I use drugs, so the place I get to go for medical care is REACH. I don't get to talk to my regular doctor about that.
Okay. I had a couple more questions. One is, well, comment. Thank you for pointing out that OASIS, New York State's OASIS, has revised its guidelines to incorporate harm reduction, and that the rollout's been difficult. I wasn't aware that they revised their guidelines in 2019, and to me, that sounds pretty major. The other questions I had to do with, you mentioned other existing models. One being the example of a 24-hour crisis center. And I just wondered, in your view, I don't know if you are thinking of one in particular that actually exists, or if, you know, or you're just using the example. In your view, is the emphasis in a 24-hour crisis center on the crisis or on the 24 hours? So for example, would a person you mentioned Narcan kits, you mentioned emergency supplies, emergency medical needs, things like that. And I definitely understand the, embedded types of emergency services in such a center. But do you think, and I understand there's just one person, that the emphasis is on crisis or on 24 hours, or should be on one or the other?
I think the emphasis should be on 24 hours. For our community, I think that's the thing we don't have. And so
Okay,
that's an Ithaca specific answer.
okay.
If I was going to answer that question for a different rural county, I might say it might be important to have a crisis center that wasn't 24 hours.
Okay.
But for here,
Got it.
yes, I think that the need is a 24-hour space.
Thank you. Also, this is a little bit, I don't think it's totally a side note, but if it's not applicable to today's conversation, you want to address it on another day, that's fine. In terms of STAP itself, I can't help but notice that AIDS is in the title, or used to be. I don't know if you normally go it seems like you normally go by the acronym, but my thought there is that, and you shared examples of, that very compelling data about Syringe Exchange being the single most effective medical intervention for prevention of HIV, which, again, that's a really important thing that I did not know before. But my question has to do with, I feel that there's a community perception that STAP services are really related to homelessness in some way. And I'm not hearing, or at least in your name, and I should have reviewed your mission statement again. But to me, so it seems like you serve people who are homeless or who are unhoused, but I'm not getting the sense necessarily that that is core to your mission or your vision or the goals that you have. Could you speak to that at all? Would you agree with that assessment or not agree?
Well, what I would say is it's not the primary piece of the mission to do housing, but because we offer support services for individuals with chronic illnesses, housing is one of the ongoing unmet needs for all individuals with chronic illnesses and poverty. It just is. We do have 3 housing grants that we operate for scattered site rental subsidies. I will say to you that 2 of those grants are specifically for people living with HIV. So most of our clients don't qualify for those housing pools. One of them is for high utilizing Health Homes Medicaid members who are homeless. So some individuals that we serve through the Syringe Exchange might qualify for that housing program, but that housing program requires you to have Medicaid, and many of the individuals in the Syringe Exchange, although eligible for Medicaid, are uninsured. And so the reality is that they are also not eligible for those housing subsidies. And the state has final approval for that particular grant because it's Medicaid redesigned team money. So the parameters around who is eligible has pretty high metrics as far as admissions to the hospital or visits to the ER. And those are parameters set by the state, not by us. But it's specifically, again, for those high utilizing Medicaid health home members. Most of our individuals are not considered to be high utilizers because most of them aren't often engaged in care. So they don't have a lot of claims data to back them up.
Okay. So that was
Anissa, are you suggesting,
yes.
are you suggesting that might be a good way to go? I'm about to redo the strategic plan.
Well, I'm not suggesting, I'm not, at this point, I'm not suggesting anything. I wanted to say, it was a question. It's a question that I've had actually, as community members, like, come forward and talk about situations on the block. I think you've provided some very specific information, Michelle, and I think, and I want to just reflect back a little bit more and make sure I'm understanding, but what it sounds like is, of course, there are people who are unhoused that are using your services, just as I would say there are people that are unhoused that are using almost any service that's out there, including medicine, including going to the grocery store, including going to neighborhood mom and pops, all of that. So because homeless people are in our community, people are going to be serving them, right? Or hopefully would be. And so it sounds like, with your, perhaps it was a growing awareness that, more of your service population might have had a housing need that you've sought or received, been awarded grants to do housing. I guess my point is, or maybe it's not a point, but really a question, is that there are agencies that are set up specifically and only really to help people who are in a houseless situation. And that wasn't how STAP got set up. STAP was really an agency that was looking to prevent communicable diseases and implement a harm reduction model. And of course, there are overlaps with harm reduction in housing, which is known as Housing First. But the kind of the origin, or I would say like the core, or the, central to your mission is that disease prevention more than something like homeless prevention or addressing homelessness. Would you agree?
I would agree. I mean, we have actually operated housing grants for 25 years now, so it's not new. But again, those grants were specific for people living with HIV and AIDS. The Medicaid redesign team dollars is a newer pool of money. I would also say that I think part of the community perception around the fact that perhaps we serve individuals who are unhoused has to do with people living on our porch. And the reason that people are living on our porch is because they don't have somewhere else to live, and we have a porch. It's also true that several of our staff, went through and were able to do the COC assessment so that people could get on the waiting list, and they went through the training to do that. And our clients feel comfortable to do that with our staff, perhaps, rather than other humans. It's also true that we will be the people who sign the attestation that they are homeless when they have to prove to DSS that they are homeless and they don't have any other way to prove it. We will sign an attestation that says, yes, this person is homeless and they've been living on our porch. Right, as the attesting outreach worker that they in fact are unhoused, and we have seen that. A lot of service providers won't do that. I don't know why that is or isn't, but the reality is that a lot of service providers won't provide that attestation, and we will, because it's easy enough for us to see that you're there sleeping on the porch when I come in at 8:30 in the morning and I hand you a cup of coffee. I think also because people feel like that is a space where they're not going to be run off, would be my other guess. We have given permission to IPD repeatedly to come on the porch and come on the property and patrol after hours. That has been done in writing over and over again. But the reality is that IPD does not desire to do that. They have never consistently done that, even when they have been asked to do that by the community or by ourselves. And they now have said to us that they're not even certain that that's enforceable, because they're not certain that the DA will allow them to enforce that even with our permission.
Okay.
So it doesn't feel like there's a resource after hours when there are concerns for disturbances on the porch, when we have given permission to law enforcement and they have declined to do so.
Okay. That's very helpful. All of that is very helpful information, I think, in illuminating and clarifying, untangling. There's a lot of perceptions out there. And I'm not saying that it's either good or bad that, serving, that homeless services are or are not core to your mission. I just think is an important point to discuss. And since you mentioned or brought it up, this is a interesting point worth exploring a little further. STAP's having provided to IPD permission to come on property for enforcement reasons. Do you feel you can share a little bit more about what those circumstances are? Was the permission at the time it was granted like kind of an umbrella anytime it's needed? Did it have to do with a specific situation? Is there anything else that you can share with us that will help us understand how that request or not request, but how that permission came about?
Sure. So, I mean, historically, before the gate on the driveway, there was open access to the back. We were asked several years ago at this point, I think 3 years ago at this point, to provide a statement allowing IPD to go on the property after hours if there were concerns, if there were disturbances, if they had, sort of probable cause, if you will, that's not the words they use, but if they had a reason to go look to see if there was a problem. And we provided them with that permission in writing so that they could go after hours. They had permission to be on the property, to ask people to remove themselves if they needed to. And then if people didn't move along, then they could ticket them for trespassing or do whatever it is that they deemed was necessary for the situation in that event. After the installation of the gate and the driveway no longer being accessible, we contacted IPD to provide them with the code to the gate so that they could access the gate after hours in the event that they needed to, just like we did with bangs, because we don't know that there might not be an emergency after hours, and we don't want law enforcement or emergency services to not be able to get to them. In addition, we redid the statement on their own special IPD form as per their request, to give them permission again to come up on the porch after hours, to clear people who may be there, to request for them to move along, and to give them permission to ticket or arrest or whatever they might need to do to address that situation. The response that we received was for them to say, essentially, the DA wants to make sure that someone would be able to testify if we're going to make arrests based on the statement. We're currently verifying whether or not we can enforce this voluntary statement. So once the powers that be decide, I will let you know.
Okay. It's interesting to me to learn this. I'm not at all versed in what criminal procedure is, if that's what we're going to call it. But, you know, sounds like what you're saying is, of course, we know that police must have probable cause to approach, for example, a motorist, to stop a motorist, etc. And I'm assuming that police need similar probable cause or a signed warrant to enter private property.
They don't. They don't. With the voluntary statement, which is on file, it allows them to go onto the porch when they see someone on the porch, since it is posted on the porch that you are not supposed to be there, and allows them to ask them to move along.
Okay,
there doesn't have to be any particular, there doesn't have to be a precipitating incident or a problem.
Okay. And it's also, you're also pointing out a difference. We're talking about, like, so last week, the Joanne Cornish and Rob Beldewall both mentioned that the code inspection officer needs to stand in the public right of way, cannot enter private properties, can't be on private property, can't go behind a house. But the police, we're not talking about going inside, but the police, you know, with your voluntary statement, could access the outdoor space,
correct,
to do any policing that seemed necessary.
Yes, and again, that's specifically after hours. So I want to say that again. It's not during business hours, because we don't want the police to come down the driveway and come into the anonymous syringe exchange during business hours.
Yeah. Okay.
I think we also need to note here that probably for about 6 months, we have been trying to get a fencing contractor to come and assist us in fencing the porch and the front yard off from the street. So there are some supply chain interruptions that are getting in the way of that. But that will probably be the long-term solution to the problem.
Okay. Yeah, that was going to be my question, supply chain. Okay, thank you. Thanks for that information. Other questions or comments? Okay, seeing none, thank you. Very illuminating. I really appreciate your presentation. And Michelle has said that she'll provide the slides to us, which is very helpful. Now I wanted to move to the next, I don't want to call it an exercise. I feel like you're a task force. You probably don't want to be doing exercises. The next thing that we want to accomplish, and that is, as I said earlier, I would like each of us to take some time to brainstorm our own list of categories or broad concerns that are salient to the 300 block that we should discuss, explore, and or create recommendations for. And how I'm going to suggest that we go about doing this is I'm going to set my timer for 5 minutes. I'm going to encourage everybody, you can leave your camera on if you want, but I encourage you to turn it off and turn off your, mute yourself. And I'll break in at about 5 minutes and either give a little bit more time, depending on whether I need more time to do my list, or call us back in, and then we can share what's there and see what's common, and then kind of move on to the next steps. So I will do that now. And also, like I said, it's 5 minutes. So if you need a break, and you can do your list while you're taking a break.
Okay. Anissa, can you say
Please
it
feel free.
again? Exactly what we're supposed to be writing down.
Okay. So brainstorm for yourself a list of what topic areas or concerns you feel are most salient for the 300 block, and that this group should explore, find out more about, and possibly develop recommendations for. So I'll just throw one out: trash. That I've heard a lot of comments that there's a lot of trash out there. I'm not saying, and you don't need to like explain whether it's the most important or the least important or where it is on the spectrum. I'm not saying that. Just a list of things that you've heard or seen or observed yourself that you think are a concern on the block, and something that you feel the committee should, work on. I'm going to turn off my camera. I'm going to mute, and I'll be back with you in 5 minutes. Okay, I'm gonna give you 30 seconds or so to wrap it up, and then when you turn your camera back on, I'll know you're ready. I also should have mentioned to people at the beginning that I'm not gonna like require people to share what they wrote. Hopefully you will email them to me if you don't wanna share them out loud. But it would be helpful if some people would share at least some things on my list. And of course, if nobody does, I'll just share my list. Okay, just waiting for one more person. Okay, who would like to share some other things?
I can go first.
Great.
You know, my preoccupation professionally and personally is with nightlife. So a lot of my stuff, a lot of my categories are about, you know, the 10 to 9 a.m. Time frame. The need for a social space, a 24-hour social space as a business. So, you know, entrepreneurial concerns, you know, folks being able to, you know, start their own businesses and have gainful employment, and having social gathering spaces that are available 24 hours that provide food and sober beverages, things like that. Support for businesses late night. A lot of businesses that are already established don't feel safe operating at night. And we can find ways to support them doing that. And then trash pickup, the city picking up trash after, you know, 9 p.m. and on the weekends, and on West MLK as well as Green Street. I think it would be a huge help. Sort of, you know, and this is a broad category, but, you know, social interactions, boundary setting, de-escalation, us being not quite so afraid of each other. I don't know, that's a very broad category, but I don't know, just brainstorming.
Great. These are all really helpful and really good. And yes, reduction of fear is actually something that was on my list too. These are really helpful, Ashley, and I, especially because these are not ones that I would have thought of myself. And this is the reason for doing this, is I know that everybody will have things that some of us haven't thought of. So would anybody else care to share at least some of theirs?
So I'll piggyback on some of Ashley's when the evening or early morning hours. Obviously, we have a large employment space, and one of the pieces is lighting in that area. And, you know, looking at the lighting and safe walkways. Some of that also has to do with cleaning up trash and other things in the different spaces. Kind of a community pride too. I think we discussed it last time that there are some people that live in that area, housed or unhoused or wherever that living space is. But then how do we create that sense of pride in that community for the businesses as well as the people that are coming into that? There's definitely a lot of changes to come throughout State Street. And so how do we build that up? And so I think that's a piece of that. And, you know, I think you kind of talked of it, both Ashley and Anissa, about that safety piece. How do you build that sense of safety there? And does that include community policing? Does it include the safe response mechanisms of things like having community policing, having safe spaces, public spaces, having more lights, having trash pickup? So all of those things kind of tie together.
Absolutely. Great. Thanks so much, Amy. I really appreciate that. And yes, on Joanne's slides and in her talk last week, she talked about the civility component. There was another, I don't have the summary in front of me, but there was another word associated with that. But so yeah, I have that on my list as well. Anyone else want to share something or a few things that they that you haven't heard mentioned yet?
I'm going to say bathrooms.
Okay, great.
I need it. They
Near and
need
dear to my
it.
heart. Yeah,
I mean-
and I'm gonna go ahead.
Well, I was just going to say the reality is we're one of the only people in walking distance that has a publicly accessible bathroom at this point.
Yeah.
And that's a big community problem. It also means that it's a staff problem because then we end up with feces and urine on our property now that the porta potties have been removed.
Absolutely. I think that, and I was, maybe I sounded flip when I said it's near and dear to my heart, but I personally, it's a human need that people have that they cannot prevent. There is a need to utilize the restroom. So not having them is not at all going to deter the need. Anything else that people would like to share at this point? I'm going to ask you to send me your lists. And I think we'll continue to either build a list or maybe take some things off. There may be we may in our exploration learn some things that allows us to remove some of these.
I think it's not at all helpful having 4 vacant buildings on the block.
Mm-hmm. Mm-hmm. Yeah, that was something that was touched on last week, but I mean, to the extent that it was, here are the ordinances on the books and here's what can currently be done. And, that's, I would consider that the minimum, or what the city can currently legally do. Perhaps there are other community responses that we can recommend. Okay, anybody else before we move on? I think there's only you, Kathy. I don't mean to call you out.
I took it a little differently because I
Yeah,
don't know, my brain just went there. I was looking at more like information that I felt I would need before I could
Great.
move forward.
yeah, helpful. Let's hear it.
So I had things like exactly which activities are making people feel unsafe
Mhm.
instead of trying to guess what
Yeah.
they are.
Yep.
I had things, I did have the unoccupied buildings, what is the plan for the unoccupied buildings? I actually had as my first one, why are people sleeping there as opposed to elsewhere? Just wonder what people's, I mean,
Yeah.
the staff's there, but and what's going to happen as the weather gets colder. That's in other people, what are other concerns of people who might either live or, do business on that block, and any suggestions they might have or thoughts they might have.
This is great. So I'm really glad that you took that approach, Kathy, because again, that's really helpful. I want you to send me your list. I think that, and these are all completely appropriate for us to explore and invite people in to talk to us about, or I have talked to a number of people who utilize the block in various ways, but need to do more of that. I'll say that one of my things on my list was wanting to understand or be able to know enough to see if it's what are the community responses that are reasonable in terms of are there ways that community members can get involved as volunteers to do anything, and or what are the staffing needs that would be necessary to implement any of the kinds of recommendations that we might want. Now, I don't know that this group is going to get to we're going to need exactly 5 people, but perhaps there's a recommendation we'd like to utilize both, one, whatever. That's something that I would like to be able to explore, because I do think that people are going to be needed. So I want to know how that's going to look. So please send those to me, and then what I'm going to do is follow up with a survey. I really ask your forbearance in my surveys. The reason I find that they're helpful is because, you know, yes, we could whiteboard it here on Zoom, but I just feel like it will be, I would like to consolidate what you send to me and then send out some other questions for you so we can prepare for our next meeting. And these categories are going to help us bring together other speakers and so on. So on that topic, I want you to feel free at any time to bombard me with who you want to hear from. If it's a specific person, a specific group of people, you probably already have a sense of who I'm already reaching out to from the kickoff survey that I sent out. There were some general themes. I was asking you how much you knew. So please, you know, if there's just somebody that you want me to talk to, I will definitely reach out to them. If you want to hear from certain people, same thing. So before we go too much further, I want to go around and address what our soft action item, which is the proposal to understand how best to vote in this group. So I put out the proposal that voting in the group should entail putting out what the question is, and in this case it is, how shall the group vote? My proposal is that after the statement is made of what the voting item is, there be discussion, any discussion is needed, then the proposed solution, and then people vote on it. So my proposed solution is that we follow that path. We don't do a Robert's Rules type approach, at least to begin with. It's more like, how would you like to vote? I'm proposing that we vote by discussing and then moving around individually, everybody vote. So with that in mind, Ashley, you're first on my screen. Would you say that you would say yes or no to that?
I'd say yes to simple voting.
Okay. All right. How about you, Michelle?
Yeah, I think that's fine, especially as you
Okay.
mentioned earlier, if we bring in other community members. Doing Robert's Rules is complicated for the board, much less for community members.
Yeah, agree. Okay, John. Okay, Kathy.
Yeah, I'm fine with the simple voting.
Okay, how about you, Amy?
I am, as long as we can find the mute and unmute buttons easily, so.
You always have this option. Okay, thanks. Okay, so I just wanted to leave with a couple thoughts. One is, Michelle, when you mentioned it in your presentation, the harm reduction example being a 24-hour crisis center, I asked my questions for a specific reason. And I think I don't know if I ended up putting this on the agenda or not, but I just wanted to share an observation. This is not a best practice or even necessarily a successful practice. I haven't evaluated it, but in a community that I used to work in, there was a 24-hour place that it was focused on homelessness, people who are homeless or found themselves even temporarily for the night without a place to be or stay, that anybody could go to without ID or anything like that, provided that they hadn't had a recent violent incident there. It had outdoor space where people could be outdoors in a courtyard, and it had an indoor space, very sparse, just basically plastic chairs. This was a place that many service providers ended up referring people to, because if people called them at night or they knew that it was going to be night when they arrived, that the shelters were already closed, needed to enter shelter at a certain time. And so it was kind of considered a place of last resort. There was not a lot of staffing for this center. And I will say that I think it became a de facto 24-hour place. I do not think that it was initially opened with the intention of being a harm reduction place. That's an assumption based on just what I know about the organization. And there was not, like I said, there was not a lot of staffing. So there was not necessarily a feeling that it was a safe place, but it might have been safer than being on the street. So I mentioned this only because it was an existing solution, and I just wanted to point out that the that's why I asked the question about 24 hours or crisis. And that's why I also am interested in understanding how staff members and volunteers, et cetera, can aid in any sort of place that exists like that. Because I think that there can be places instituted that provide safety and 24-hour availability and emergency services and all the things, all the good things. And then I've also seen examples where it kind of defaults to and is de facto that, but never necessarily funded in a way that creates all the level of things that we want to see. So I just wanted to point that out or share that from my own experience, because it's one of the few places I've experienced or know about that was available 24 hours to basically all comers. And with that, I think I just wanted to let you know I'm looking forward to our next meeting, which will be on November 18th at 2:30. Please feel free to, as you've mentioned in advance, those of you that have mentioned in advance, John, I know you're not available next week, but let me know what your availability is. And I'll leave you with the thought that the first Saturday in November is Book Lovers Day, apparently. So if there's any book lovers here, enjoy, read up, maybe follow some of Michelle's links. I'm sure you'll get to a bibliography somewhere. And thank you so much for being here and for all that you're doing on this task force. I really appreciate it. Send me your lists.
Thank you, Anissa. I'll send the slides out to everyone as soon as we're done here.
Yeah, thank you, Michelle. Appreciate it.
Yeah. Absolutely.
Okay, bye-bye,
Thanks so
everyone.
much.